Good
1 minute.
morning.
Just wait. Just a
Good morning, good afternoon, good evening, wherever you are in the world today. Thank you very much for joining us in what I believe is going to be a very, very exciting satellite session in this conference. The title of this session today is Altogether, Stronger Health Systems for UHC and Health Security. What I wanted to do in the briefest of introductory comments is to give you a sense of what we try to do and particularly take you through the menu with the appetizers, the main dishes, and the main debate we have today. This session is led by the UHC 2030, as you know, a platform of a wide range of stakeholders that working together, a very impressive, I may say so, initiative that brings also stakeholders from the public and private sector around the achievement of the UHC, of the universal health coverage. And we root this session in two main areas. One is this idea of common goods for health. We've been making a case for quite some years now about the need of collective action, about the need to invest on a series of common goods for health, which would be key to strengthening health systems, which will be key to achieve universal health coverage and health security. So that's the first one, is the common goods for health. How we use that concept, to strengthen, to achieve universal health coverage. So that's our first pillar today. The second is, surprise, surprise, COVID-19. How does COVID-19, how does that crisis helps us to make the case for common goods for health? I don't want to fall into the stereotype these days about taking advantage or not to waste the crisis. I think this is a stereotype. This is one that's been overdone far, far too much. Still, what does COVID-19 tell us about investing on common goods for health? What does it tell us in those countries where had more resilience and preparedness to the pandemic? Do we see that there were countries where there had been more investment, where this collective action was there? In many ways, what we want to do is to demonstrate that with the COVID pandemic, with the number of case studies, with the number of experiences, whether and how we can make a stronger case for investing on common goods for health. Indeed, if you look at COVID-19, it is the ultimate example of externality. It's the ultimate example in which you want common action to strengthen, to address COVID-19. And again, if something COVID-19 is reminding us once again about the vulnerable populations, about the governance failures of our systems, about our lack of our weaknesses in our public services. It's yet another crisis, albeit a very dramatic one, albeit a very painful one, but yet another crisis that reminds us of some of the weaknesses and the problems of our public health services, our finance, our inability or lack of ability to protect our vulnerable populations. So in front of you, what you have is the menu for today. In that menu, we'll start with Agnes Sukat, who's going to be giving us a sense of setting the scene about common goods for health. Then we'll have three of these common goods, as it were, or three ways to look at these common goods for health. One is primary healthcare performance. Another one is around the healthcare, the health data, and the importance of investing on common health data systems. And then we're going to be talking about the vulnerable populations that, again, in that crisis have suffered in particular. Then we will have Professor Son-Man Kwon from South Korea, who's going to look, as it were, in a horizontal way. He's going to be looking at how these common goods for health have made a difference in South Korea, how looking at the COVID-19, looking at the crisis, at the COVID-19 crisis, and how these common goods have helped for the preparation and the preparedness and the resilience for the pandemic, have helped or not helped. We'll see the lessons in a minute. Then we'll move into a debate. We'll move into a debate where we want to have 3 sets of questions for all of them to try to draw common lessons across. In that debate, we'll start with a presentation around the common goods for health around Ebola rather, in Liberia. So we'll see again, like for South Korea, how these common goods for health integrate under a case study and how we bring them together. I should introduce myself, I guess. It's a good hint to introduce myself. My name is Joseph Figueras. I'm the director and co-founder of the European Observatory on Health Systems and Policies. Like UHC, it's a partnership. It's a partnership that is hosted by WHO and brings a number of European partners, including the European Commission, the World Bank, which is not European, it's across the world, of course, and a number of member states. I don't have any merit in organizing this session. This session is organized by my colleague in UHC, Julia Salaki, who is going to be bringing the chat, the contributions, the questions. So please bring them in. She's going to summarize them. She's going to bring them into a debate. So bring the questions in, please, and she's going to be reflecting them. Next slide, please. In the slide, I'm sure you're familiar, or maybe you're not familiar because we're at the first days of the conference. You can access the support chat function on the top right corner of the page at any time. You see there's a Q&A. There'll be a Q&A at the end of the session, and you can use the chat platform to add questions and the Q&A as well. It's suggesting that for best user experience of the virtual conference, please view the session in full screen, and please to remind you that all the sessions are recorded. So please, next slide, and I'd like to introduce Agnes Sukat. Doesn't need much introduction. She's the director of the Health Systems Governance and Financing at the World Health Organization in Geneva. Agnes is going to be providing to us a bit what are these common goods for health, how we use this concept, what is the rationale for investing in these common goods for health. And she's going to be drawing in what I would say, Agnes, without wanting to be too nice, but I think I should be nice, about this special issue of health systems and reform that was published, I believe, in 2018 around UNGA, in which you try to thresh out, and achieve to thresh out the concept of financing and the rationale of financing for common goods for health. Actually, Julia, perhaps you want to add in the chat box a link to that special issue, which I believe is of public access, if I'm not wrong, but Agnes will clarify that in a minute. Agnes, the floor is yours. Indeed, actually, let me say that COVID-19, unfortunately in many ways, but COVID-19 is really the perfect example where common goods for health have to come on board, where externalities are at the core of COVID-19. Even neoliberal economists would agree that we do need to invest, have collective action for COVID-19, and yet we don't see that very much happening. Agnes, the floor is yours.
Thank you very much, Josep, and thanks for the kind words of introduction. Yes, indeed, as this special issue of health systems and reform on financing common goods for health came out end of 2019, the main message of the special issue was that the world had a major blind spot when it came to underfunding common goods for health, that they were that the world was blinded about what was coming our way in terms of health threats, and that we were neglecting those threats, we were ignoring them, while we were stuck into a framing of global health issues that was grounded in a historical experience of past disease. And this is really what motivated this work and the bringing together economists and public health specialists, some of them here today from Liberia and elsewhere, to bring them to think about those blind spots. When we talk about common goods for health, we launched this agenda in September 2019 as part of the UN General Assembly, because when the whole world gathered and called for reaching universal health coverage by 2030 at the high-level meeting on universal health coverage, we emphasize the fact that common goods for health should be the first investment that the global community needed to pay attention to, because it was the step zero of universal health coverage. So that we had to place common goods for health at the heart of universal health coverage and as the heart of the health security agenda. Why were we saying that? We were motivated by this concern that despite remarkable progress on health for humanity in both the 20th century and in the first part of the 21st century, with declined child mortality and decline of communicable disease that was largely linked to economic growth and poverty reduction, there were substantial risks that remained due to systems, health systems, that were not able to manage or respond to pandemics and outbreaks, non-communicable disease, evolving disease, including drug-resistant tuberculosis, but mostly the large and potential health impact of climate change and environmental degradation. And we are there. Then COVID-19 hit, validating, confirming our fears, our worst fears, that we had forgotten those important lessons from history, that collective action is essential in health because they are common goods, collective functions that need to be collectively funded. And COVID-19 made this agenda all the more pressing. We see that comorbidities with NCDs and shared risk factors, the role of environment degradation is completely apparent in the COVID-19 epidemic, the role of biodiversity and the threat to animal health. The fact that the cost of the response far outweighs the cost of preparedness and prevention. The special issue was placing the cost of the response at about 100 billion per year for 5 years. We're talking, when it comes to the economic impact of COVID, of numbers that are already, by now, in November, after 11 months of this epidemic, in the several trillions, 1,000 more times. The impact of the poor and most vulnerable, because by definition, the commons benefit the poor, because the poor don't have the way to escape through economic means. But what does building back better look like in reality? If our message was vindicated and validated by the pandemic of COVID-19, what is it that we need to do? What do we mean by common goods for health first? Common goods for health are population-based functional interventions that only the collective arrangement can finance. And that's why they are underfinanced, because markets are great things. Markets delivered on poverty decline, they delivered on better wealth for the world. They delivered in many ways on access to health services through increased economic means to invest in those services and pay for that. But there are functions that markets don't deliver. They are the pure public goods, but also the goods with the large market failures. And those have enormous impact on human health and welfare because there are a lot of market failures in health. And government intervention is required because of the large externalities that are created by addressing those market failures. Typically, there are 5 categories of common goods for health: policy and coordination, taxes and subsidies, regulation and legislation, information analysis and communication, and population services. And we know that globalization did not deliver on those. We know that there is no such thing as a global tax to fund global public goods. We know that there is no such thing as global regulations and legislations that apply to all countries to protect the health of people. There has been some efforts to it, and the framework on tobacco has been one of them. But we are still very far from what would be needed to prevent the risk of future pandemic and even address this pandemic. And this is what we collectively, and WHO at the front line of this battle, are trying now to do in the crisis, during the crisis, while we should have done it before the crisis. And as mentioned, common goods for health promote equity by definition, because the protection common goods for health provide extend to the poor and most marginalized of societies, because common goods for health are not dividable, they are not excludable. So they are, by essence, benefiting the poor, because collective action that is inclusive benefits everybody. So what are we talking when we talk about reaching the Sustainable Development Goals? Is that the very first thing we need to do is invest in common goods for health. So trigger collective action to invest in these common goods for health as the base for building health systems. These are really the step zero of health system. Those functions need to be fully funded by the collective purse, by the public purse. And these common goods for health underpin the foundations of health system, which are sectoral, with governance, resource generation, service delivery, financing, you know, this, the 6 building blocks of health systems, but also multisectoral for health, multisectoral action for health. And health systems, the goal of health system is to deliver both on health security first, investing in preparedness, investing in getting ready to address all the health threats, the known and the unknown. We know that there are a lot of unknown. And beyond that, reaching universal health coverage, making sure that people not only benefit from common goods, but also have access to essential private services that benefit their health. And this is the road towards the Sustainable Development Goals that will lead to global public health security, equitable health outcomes and well-being, but also, and we have more and more evidence of that, and if anything, this crisis is eliminating this inclusive economic growth and employment. We know since 2020 that investing in health is absolutely at the core of inclusive economic growth and the creation of sustainable societies anchored in well-being and providing both jobs and social outcomes to the societies of tomorrow. Now, the question is, why didn't we do it? Why did we not invest in common goods for health? It's not that we didn't know. There were plenty of publications. I mean, this special issue was one of them, but it built on a wealth of publication. The Ebola epidemic in 3 Western African countries in 2014 had triggered a very large number of people to think about those issues, about the future of pandemics. The WHO had alerted about disease X, which it actually said was going to be a respiratory disease and could kill millions of people and would have a devastating economic effect. So this was predicted. And this was predictable because market failures are inherent in the definition of common goods for health. And we know from extensive analysis, both economic analysis and other social sciences fields, that globalization did deliver on poverty reduction and wealth, but globalization was a globalization of markets. So it delivered on what markets can do, but it did not deliver on what governments should do. And that profound global market failure is what we are living through today. Why is it not happening? Because there is a lack of political incentives for leaders. Prevention is not visible. There is short-term thinking, and the models of democracies we have today tends to favor this short-term thinking, preference for investments that offer immediate results for re-election. A lack of salience. We don't know because it is a black swan. We just see the past. We see what has happened in the past. We don't see what is going to happen in the future. So there is no clearly defined or widely perceived problem. There is no crisis or opportunity. That's what happened before COVID-19. Now we do have the crisis and the opportunity. What we've seen with the MDGs movement is we also foresaw an increased demand for private goods as countries get wealthier. That was the impact of globalization, of markets, is advocacy for access to private services rather than advocacy for investment in the collectives. And elites not thinking that the redistribution and financing of common goods for health is their interest, so elite going the private way. But I want to insist today, because this is an event that is sponsored by the UHC 2030 partnership, which is a partnership that brings together civil society from all over the world, that probably the most fundamental problem underpinning the lack of investment in global common goods is a lack of a collective identity. Because collective action requires all of us to think that we are in the same boat and that we are one and the same people on the same part of one community of global citizens. And there is still, and it just opening the newspaper or switching off the TV or looking at social media today, we see that the path towards that global collective identity is full of difficulties. So this is today really a call to action. We see that COVID-19 has relaxed some of these constraints to create a potential political window of opportunity. We do have salience today. We have a clearly defined and widely perceived problem. Everybody on the planet today is affected by this pandemic. It's for the first time one problem for the entire planet. And that's very unique in history. There is a crisis, which means there is an opportunity. You mentioned that, Joseph. So we have this unique opportunity to build that common identity and to trigger concerted action and commitment from this global health community. We need to capitalize, move beyond focusing on specific disease to building systems that are able to respond to the health threats of the 21st century, which might be very different from those we've seen over the past 50 years. The past burden of disease might not be that helpful in the future. Foster a common identity at subnational, national, and global levels. Build this salience across all communities, getting the sense that has been gotten now in the Ebola affected countries about the importance of investing in common goods for health, and enable this community engagement and the grassroots initiative to trigger that collective action, to trigger an inclusive social contract and demand actions from leaders. So what is Winnie the Pooh telling us about this? But how will we know if the pandemic guidelines worked? Asked Piglet. How are we going to measure whether we are successful in common goods? The world will think we overreacted, said Pooh. So even when we are right, everyone thinks we are wrong. Welcome to public health, said Pooh. And Piglet understood. Thank you very much.
Brilliant, Agnes. That was really beautiful. Thank you. That was impeccable. That was impeccable. And with Winnie the Pooh and Piglet at the end, what a message. But let's remind ourselves, we no longer should think ourselves of the Cinderella that is now been invited to the ball because of the COVID. Let's try to stay in the ball somehow as long as possible and take that opportunity. Agnes, I do talk about COVID as the crisis, as not wasting a crisis, but as a reminder as well, Agnes, that we've been wasting many crises already. Remember, in the financial crisis, the economic crisis, we're talking about not to waste that crisis that was affecting the same vulnerable populations, and I think we wasted it because, as you said at the end, why haven't we investing in common goods? So you made an impeccable rationale for collective action on common goods, the externalities, the impact on human health and welfare. It's been even more pressing than ever now because of the COVID-19, not only on health, but on the environment, on many others of the SDGs. And please hold that thought, hold this list of challenges, this list of reasons by which we did not manage as much as we wanted to invest on these common goods for health and how we can address them now. And I think the points about the lack of salience, the lack of collective identity, the lack of political and electoral incentives, these are the ones we're going to be addressing in a minute, more than a minute, but in the debate. So we'd like to hear from you, colleagues, about how do we address these well-known challenges now with the COVID? How do we use them? Why use this opportunity to address these ongoing challenges? So from the common goods, now let me move to the first common good, as it were. If you want to change the slide, please, and put the slide with Beth Tritter, Executive Director of the Primary Healthcare Performance Initiative in Washington. No, I think it's not Craig, but Beth Tritter, yes. All of a sudden you changed a little, Beth. So Beth is going to be, it must be because it's light there. Beth is going to be talking about primary healthcare, the first line of defense. Primary healthcare is indeed at the core, is the backbone of UHC. And since Almaty, and then going through in 2019, Astana, we had the justification and the rationale for investing in primary healthcare. We know about its cost effectiveness. We know it is at the key of UHC and access. We know it's the area to invest, but we haven't done terribly well, in some countries better than others. So the question, Beth, to you is, do we have a better chance now? Can we make a better case now with COVID? Clearly, you show us, illustrate us, and remind us that with COVID-19, those countries where primary healthcare has been more present and strong, we have managed to be more resilient to the pandemic. So Beth, the floor is yours to remind us once again about the importance of investing in primary healthcare and later on using COVID as a rationale to further invest in this area. Thank you, Beth.
Excellent. Well, thank you very much. And I just want to say, to kick off, I guess what I'll say when I get to the end of my presentation, which is that I agree with everything Agnes just said, and that we really do have this moment right now that we're in, which is certainly a moment of great challenge, but also a moment when people are focused on common goods for health. And I think people are focused on primary healthcare as well, as part of that agenda. So this is really a moment that's sort of pregnant with possibility for how we move forward in building health systems. So I just wanted to thank UHC 2030 for putting this discussion together and for making a space for primary healthcare. I am, again, Beth Tritter. I'm the Executive Director of the Primary Healthcare Performance Initiative, which is a UHC 2030 related initiative and is a global platform that's focused on transforming primary healthcare systems as the foundation of UHC. And our partners are the Bill and Melinda Gates Foundation, the WHO, the World Bank, UNICEF, Ariadne Labs, and Results for Development. And we work together with country health ministries and other stakeholders to improve primary health care, beginning with better measurement. Thank you. So I want to speak for a bit about how primary health care, and particularly a strong primary health care system that can meet people's needs at every age and every stage of life, is an important common good for health and can help lay the foundation for UHC and health security. And what you see here is excerpted from the Declaration of Astana, which was endorsed 2 years ago by world leaders, and renewed the promise of Alma-Ata from 40 years before, making a commitment to strengthening primary health care as the cornerstone of resilient health systems and the most effective pathway toward health for all. And at Astana, we laid out a vision of PHC that's defined as having 3 components. So one is meeting people's health needs throughout their lives. And I think the second 2 are really important as well and directly relate to the conversation we're having today, specifically addressing the broader determinants of health through multi-sectoral policy and action, and empowering individuals, families, and communities to take charge of their own health. If you take these 3 elements working together, what you have is the foundation for strong health systems that can prevent, detect, and respond to infectious disease outbreaks, and then also improve health outcomes for the world's most vulnerable people at the same time, and strengthen a broad and inclusive movement for universal health care. And what you see here, I guess if I had to sum up the relevance of the Astana Declaration to our topic today, UHC and health security, is that I would say that the old adage that the best defense is a good offense. And what I mean by that is that primary health care is not a tool that you can just sort of construct and slap together anew in a moment of crisis as a quick response. You really need to have laid the foundation before the crisis hits. And that was the vision 42 years ago at Alma-Ata. It's still the vision of Astana. And I think just 2 short years after Astana, less than 2 short years, really a short year after Astana, we've seen the importance of that advanced planning and laying the foundation of strong primary health care. What the vision recognizes is that health security is not just about preventing, detecting, and responding to pandemics, although that's certainly an important part of it. It's also about securing people's health every day with a system that's resilient and flexible enough to meet their routine and essential needs in times of crisis and in calm. And I'd like to say that a system built on PHC, we focus a lot on the services that are delivered, but it's really not just a specific intervention or a collection of interventions. A PHC system is really more of an orientation. It's about how you deliver those services and making sure that you're delivering them in a way that's people-centered and that's really deeply rooted in the needs of the community. Next slide. Oh no, could you go back please, Julia? Yeah, that's great. So I'm not going to go through the whole schematic here, don't worry, but this is the conceptual framework that PHCPI has developed to really tease out elements of primary health care. And I'm putting it up here to illustrate my point about PHC being about more than a collection of services. So what you see here is that we've specified elements of the overall system that need to exist, such as a solid policy framework, good governance, and the ability to prioritize based on the needs of the population. We've also, we've detailed the hardware of the system, the drugs and supplies, the infrastructure, the workforce and information systems that need to be present in order to deliver on a PHC approach. But when we developed this, we took pains to also enumerate the elements of service delivery that make a PHC system strong or weak, including many things that are not often at the top of the list when assessing health systems. And these are things like whether health facilities are well managed, not only well stocked, but well managed, whether providers are competent and properly motivated to do their jobs well. Things like patient-provider respect and trust. So do people actually believe what their providers are telling them? Do they view their providers as a source of trusted information they're likely to follow? Does the system proactively reach out to its population, engaging deeply with the community to understand its needs and anticipate them before they become crises? To what extent are people empaneled with a certain team of providers? So in other words, do providers know for whom they're responsible, and do people know who they can turn to meet their health needs? And when people do access care, is it comprehensive, coordinated, continuous over their stages of life, and centered on meeting all of their needs holistically rather than just 1 or 2 at a time? These are relatively intangible elements of the system are vitally important to UHC and to health security. I think you can see very easily as I've been talking through what the connection is. And they're also, as you might imagine, really difficult to measure and rather poorly measured. In fact, when we at PHCPI sat down to map available comparable indicators for these core elements of a PHC system, we found no indicators for population health management and facility organization and management, and precious few for access, quality, and availability of effective primary healthcare services. This makes it really difficult to target efforts to strengthen these elements of the system, which I think is one of the reasons why the global community and countries might be shy about investing in some of these common goods. Okay. So now that we've talked about the what, just a few minutes on the how. So how does the existence of a strong PHC system really make a difference to health security? And I think to UHC, it's pretty well established. And I'll just briefly go through these. So readiness, so a system that's based on trust, that has a track record of people-centeredness and comprehensiveness, that understands the people it serves and is proactively in contact with those people, and that recognizes the multi-sectoral nature of health and coordinates with other sectors. That system is going to be better equipped to detect and track outbreaks and to communicate with people about how to keep themselves healthy. It should be the first line of defense against threats. Response and recovery. So trust comes in here as well. Effective testing and tracing, treating people who are ill. It really depends on people's trust and confidence that the health system is there to serve them and that recommended public health measures can help keep them safe. And that trust relies on the people-centered orientation that primary healthcare providers show in their daily work. And once vaccines and therapeutics are available, PHC becomes the primary mode of delivery for those as well. And finally, resilience. You know, we've all seen the estimates of how COVID-19 has affected the delivery of essential and routine health services. And systems that are better set up to meet people's needs every day, that are embedded in the community and deeply familiar with the community's needs, will be better able to continue delivering services when a crisis hits. And some of the adaptations that we've seen adopted broadly over the last several months, like increased use of telehealth, for example, or an uptick in home visits, are part of this resilience that we're seeing. So finally, I would say my recommendation is pretty simple and also a real tall order here. You know, as we continue to work toward UHC and global health security, PHC really needs to remain at the core of our approach. So it's tempting to troubleshoot at a time like this. And when the need is so great, you want to attack challenges in the order in which you think you can take them on, so in a piecemeal way. But we really have this moment, building on what Agnes said before me, that countries and development partners are focused on how to recover and then how to prevent the types of shocks we've seen emerge in the last 10 months from happening again. So it's obvious that our current approaches haven't worked. We've underinvested in a great many areas, and perhaps our orientation hasn't been correct. But in many ways, the answers to the challenges aren't new. They lie in commitments we've already made 40 years ago. We made them just a couple of years ago, and in principles that we've already laid out, like in the Declaration of Astana. And really, that's what I'll say is sort of the key to how we want to move forward. And I look forward to the conversation with the rest of the panelists and with the participants in the session to talk a little bit about where a PHC orientation has worked and how we might all work together across platforms and across stakeholders to increase a focus on PHC as sort of the core of our agenda moving forward. Thank you.
Thank you very much, Beth. Thank you very much indeed. That was impressive, really. 10 minutes, you managed to go through the logic and rationale for primary healthcare, how cost effective, its key components. And I enjoyed very much your 4 R's, actually, the readiness, responsiveness, recovery, and resilience, which are indeed tied to primary healthcare and adds to this logic and this rationale for investing in primary healthcare. I like as well that actually at the very end, Beth, you link, and actually still the slide there that you can leave for a minute, you link very much primary healthcare into 2 areas that come actually now. One is the importance of data, the next slide, the importance of data, and then the importance of having civil society involved. So let's therefore actually move to data. Let's have now the slide with Craig Burgess. He is development cooperation specialist and part and leading this health data collaborative secretariat. It's fascinating what this group are doing in the division of data analysis and delivery in WHO headquarters. I am really, Craig, genuinely fascinated about, I was looking at that the other day, the way you bring different initiatives and look at data from a common perspective, trying to align resources, align initiatives. It's fascinating, Craig, that if there is a common good, a public good, if there is an area where externalities are fundamental and we need to work together, is in common data systems. And yet we still see huge fragmentation, we still see huge competition between donors and groups trying to all put in place the data systems in member states. It keeps bothering me and fascinating me at the same time, but that's the story of your profession right now and your devotion. So tell us more about that and how perhaps COVID, in which the lack of data has been the Achilles heel of many of our countries, maybe COVID-19 helps us to get our act together in investing in common data. Craig, the platform is yours, and please, we can have the presentation, which is actually on access and use of quality data, a vital foundation for HSS, health systems strengthening, and health security.
Thank you, Josep, and also thank you to the UHC 2030 team for inviting the HDC Secretariat to present on behalf of the HDC. So as you heard from Josep, my name is Craig Burgess. I work in WHO, and WHO currently hosts the HDC Secretariat. And what I'd like to do in my few slides is just describe and emphasize pretty much what Beth has mentioned and Agnes has mentioned as well, is the element of trust and why data is important, and then go on to describe some challenges, opportunities, and then lastly, talk a little bit about the opportunity for HDC. So Julia, could I have the first slide, please? Thanks. I'm hoping you can see the first slide. So Julia, is it possible to put the first slide on? Great. Just bear with us. Okay, so thank you very much. So the first slide is really fundamental because, as Beth and Agnes have both said, trust is at the heart of a lot of what we do and a lot of what is important for UHC and health system strengthening. At the heart of all that is data, and data is an asset, a strategic asset, but it's also a commodity. It's currently bought and sold, as we all know, in many different fora. So how can we ensure that the data that we use in its rawest form is processed appropriately and ultimately used by the right person at the right time, in the right place, in the right format? Everybody's focusing on the use of data, but no one really looks at where data comes from and how it can be made more useful. And I just want to dwell a bit on the background to how information is actually gathered. So first in this data journey is the collection, and quite often we underestimate or don't look at enough the issues of how data is collected in its primary form or its secondary form. That's administrative data or through surveys. How data is stored, for example, it needs classified, especially confidential data that is specific to certain patients. How can we store it securely and make sure that it is accessible only by those that really are analyzing it and need it? How can it be accessible to groups of populations or groups of analyzers? And how is it transparently coded, for example? Analysis and validation is also important. Okay, so analysis and validation requires cleaning, modeling, statistics, visualization, all for data to be accurate, consistent, and valid and complete, so that indeed it can be disseminated and used by policymakers, program makers, and budget makers as well. And this flow of data we're calling the data journey is important because quite often we only look at a one-way flow of information, i.e. bottom to top, and we're not focusing enough on data for action, which is why we need to look at, if we're talking about quality, integrity of data, it requires strong data governance with a feedback loop from those that are using data back to those that are collecting data, so that data is actually used at the sharp end and used for action at the sharp end. And that is in part of health system strengthening. And we believe in the Health Data Collaborative that it's a strong part of health system strengthening to get this feedback loop and emphasize the data journey. Next slide. So what I'd like to do just now is just describe some of the challenges in the data journey. And there are opportunities there, challenges, back a slide. Thank you. So some of the challenges in collection, as we all know, is there's little alignment due to agency mandates. So for example, some of the global health initiatives are answerable to their boards that need data and not necessarily mandated to look at action at the sharp end, for example. Many programs are disease specific, for example, which leads to increased fragmentation, and the lack of integration leads to weaker PHC monitoring, as Beth was saying as well. So one of the emphasis that we are placing in the HDC is a much more integrated approach to the collection of data and use at the sharp end. I talked a little bit about data governance and data security, but quite often there's poor investment, and COVID-19 has shown that as well in data sharing agreements and vulnerability of data in the cloud, and how privacy and data should be based on ethics and human rights approaches. Analysis, there's very poor digital literacy and data literacy in many different aspects of data analysis, and involve the need for increased investment in statistics, statistical systems, and IT infrastructures, and the governance to do so. In terms of use at the sharp end, as I said before, there are no feedback loops, and that feedback loop that I mentioned at the beginning needs to be strengthened down back to health facility workers and those that are actually collecting the data itself. Global data tools are often not adapted to local contexts, making them inappropriate or inaccessible to many. And data is often not driving change or local action at the sharp end. Next slide. In terms of opportunities in the Health Data Collaborative, we see there are many opportunities of linking, for example, the collection of data with digital tools. There's a whole range of digital tools out there. The important thing about collection is to make sure that the digital tools are aligned with national processes and not increasingly fragmented. So at national level, there is an opportunity to coordinate and strengthen the digital collection and use of data as well. In terms of data availability and the storage, there's opportunities for increasing coordination of the alignment of financial and technical resources with country-owned priorities in health information systems and tools that can support data availability and use for primary healthcare focus. An analysis in terms of COVID, there's an emerging alignment and cooperation in many different platforms, including multilateralism as well, and the multilateral agencies coming together in different fora. In terms of use as well, data can accelerate other SDG gap focus areas and focus on potentially stock takes and with frontline impact. Next slide. I'd like to just talk about some of the COVID-19 data opportunities that we've seen in the Health Data Collaborative. And one is looking at strengthening data governance. And what do we mean by data governance? It's basically looking at the standards, potentials, and standards include policies, they include and principles, solutions, which include IT solutions, but also tools such as HEAT, such as equity tools, such as SCORE, for example, and the necessary structures that in place that are that help accountability and partnership as well. And those aspects of data governance at national level are extremely important in pivoting from COVID-19 responses into the broader SDG targets as well. In terms of data protection and privacy, again, COVID-19 has highlighted some of the cracks in policies and implementation on what is private and how data can be shared. And in the near future, you'll see a joint statement signed by over 30 UN agencies on data protection and data privacy and the best practices involved with them. In terms of adapting and scaling up global tools, there's been a lot of interest in DHIS2. It's a way of collecting data in a more standardized way in health information systems and specific apps for COVID-19. Been a lot of work on modeling COVID-19 and how modelers from across the globe can work in different constituencies. SCORE is another global tool that is essentially 5 technical packages that includes CRVS, which is basically vital registration and statistics that includes aspects of, many of us talk about the triple billion targets as set by WHO, but there's also a missing billion, those populations that have never been registered and are not registered at birth. So there's a lot of work going on just now to emphasize the global good of actually registration, which goes beyond health and goes into many other sectors as well. And then there's impact surveys that gather data from health services that are impacted by COVID-19 as well. There are also opportunities on leveraging further private sector engagement using nationwide approaches to better data infrastructure. For example, in Uganda, health authorities were very keen that private health facilities need to report into the DHIS2 mechanism at national level. And then perhaps most importantly, and I'm sure my colleague Juan will talk about this, is strengthening long-term engagement with communities and civil society to build that commodity of trust where civil society and communities are involved with the planning, implementation and monitoring of services that builds up that trust and information of data and flow of information up the way, and communities are actually engaged with the planning of services. And my last slide, thank you. Our recommendation is basically building upon the health data collaborative efforts that we feel strongly that data is a foundational investment. It provides the evidence, it provides the information on which to base sound decisions at many different levels of the system. And the health data collaborative approaches in countries help leverage partner technical and financial resources around government plans to do 3 things. One is to strengthen country health information systems, specifically working with national institutes and statistics institutes. And secondly is to align those partner resources with government data and M&E plans with a focus on using data for action on the front line and the needs for communities left behind, such as communities that are mobile, affected by fragile situations, live in fragile contexts, urban poor, or rural remote, or those affected by stigma and discrimination. And lastly, the HDC partnership, which is a group of 7 constituencies, which includes countries, multilaterals, donors, global health initiatives, civil society, private sector, and research institutes, is to consider and adapt some of the global tools I've mentioned to address data gaps and increase use of data at local levels. And that would be our recommendation, very much in line, I think, with Beth's PHC recommendations. Thank you. Back over to you.
Thank you very, very much indeed, Craig. That was excellent. A strong reminder about the need to align those financial resources, this cooperation and this support. Strong message here. A strong message as well that we'll be talking about later on as well, about the importance of data in its use as well for governance, for transparency, for accountability. And in this last slide, to highlight what's going to be the next presentation, actually, we need that data to support, to understand and support and address the needs of those communities left behind. So very nice linkage here with the next presentation on leaving no one behind in the COVID-19 crisis. So if we could see the slide of Dr. Oan Quat from Vietnam. A minute ago, Oan was in the car coming from a community of communities in Vietnam that were right now under flood, and the efforts that the civil society, the community themselves were doing to not to leave, she was saying, anyone behind, get them out of the area. I think she's now arrived already on. You are a real good example, as Anya said, of multitasking. I would not be able to do that in the process of going to a conference. Well done you. Just a reminder, you are the executive director for the Center for Supporting Community Development Initiatives. You're the founder and executive director of this SCDI organization in Vietnam. And you're going to be talking about meeting the needs of these vulnerable and marginalized groups. And I think we don't need to say that this is fundamental and core to UHC. That would be an understatement. We all know that. But I think also we need to have ourselves a powerful reminder that these populations have been left behind again and again. And we've been talking about that, as I said earlier, during the financial crisis, economic crisis, in my continent with the refugee crisis, my continent being Europe. So we're talking during those crises that are the vulnerable populations that are left behind, that those crises are an opportunity to remind ourselves of the need to protect these populations as a fundamental core of our values, but also because of the importance of these populations to be integrated and adding to the sustainability of society. But still, we seem to keep leaving them behind. And the only way forward is what Owen is going to tell us, by investing on these communities, by supporting and strengthening these communities. So Owen, the floor is yours. It's a real privilege to have you here, to have you with the kind of experience you have and expertise working directly with these communities. Thank you.
Thank you, Joseph. And I am now arrived in the hotel. So I am now in my hotel room in a province, coming back from the flood area. And it's really my pleasure and privilege to have this opportunity to talk about the vulnerable community and what not to leave them behind. The title of my presentation is Common Good for Health to Leave No One Behind. So if like Agnes also already mentioned, if we can invest in common good for health, that would increase the equity and no one would be left behind. So that the next slide, please. So I think we all agree that COVID-19 has shown us that leave no one behind is not only the right thing to do, but it's also the critical things to do. COVID-19 doesn't discriminate. You know, the president of the United States got it, and you have the poorest people on the planet got it. So they don't need passport. They don't need a car. They don't need a villa to transmit. So anybody can get it, and it can it is a communicable disease. So it's really that we should not leave anybody behind if we want this world to be safe. Next, please. So I will speak a bit about our experience during the COVID-19. In the picture, you will see the people that we met during the lockdown in Vietnam. During the lockdown, it's us, the civil society and community that went out on the street, went to the slum area to meet with people. We distribute masks to the elderly who live alone. We went to meet with people and only to discover that they have XDR TB living on the street. We met with the homeless people to distribute food, giving them masks. We meet with people who ill drug to get them to stay on methadone and to be able to continue to feed their children. We also went to the hospital. Actually, we collect donation from the community to buy protective equipment to provide to the health worker, to the frontline worker at the beginning of the COVID pandemic, because the government had not been able to respond quick enough. So we get people donate protective equipment and money so that we can provide to the health worker. And we was on the street to collect data, to correct the people who try to avoid the authority eventually trust us and give us the information. So collecting information provide protective equipment to the left behind population, to the frontline health worker, taking care of people with the chronic condition and the communicable disease, and the children and the elderly. So, so it is the community out there to reach out to people and to provide services at the essential time, at the critical moment. We see it as a collective. We have that collective identity as a community, and it is a common good for health. In this case, is services provided to people, and it is a collective financing because it's the community that put the money together. We went on the Facebook the night before, asking people to donate, and the next day we could be out on the street to distribute food and masks. So that that is, I think it is an example of common good for health at the community at the grassroots level. Next, please. So when we talk about community and civil society, I think we all agree that the community and civil society understand the needs of the population, and particularly the most marginalized people, the people who are locked up, hidden, stigmatized. So because we have their trust, they trust us, they can share us information, but also we have know-how. We know how to respond to their needs in challenging circumstances like COVID lockdown. We are able to mobilize quickly. Like I said, we decided the night before, and the next day we was on the street to distribute masks and food. Community and civil society flexible and resilient. We don't need to have the whole chain of command from the top to the down to say to make the decision. The decision can be made quickly. We can be very flexible. We can need very little to be able to respond. And when we talk about collectiveness, it is what community is about. We have that mutual reliance. We are connected to each other. We feel mutual responsibility to one another. But for all this, what I have learned over the 20 years of working with the community is that we need systems to put all these in operation in an effective manner. So otherwise, the community can be fragmented and not very effective. So system, in this case, not I like what the Global Fund use, a system for health, so we can have a community system that work for health. So just from our experience in Vietnam and in other countries that I learned from my college in other countries, in India, in Uganda, in Ukraine, that we can build common goods for COVID response at grassroots level. It's come out of solidarity, humanity, and using the community system that we have already in place. And we've done that as we have been doing for UHC. For many years, we've been trying to get people who are usually left behind to be included in UHC, to be a part of the UHC. And the community system that we are working on is really complement the health system response. So on the one hand, the health workers are working in hospital, in the health facility. We are working in the community. So we support the health system, but we also do our part so that the health system, the health worker in the health facility will have less burden, will have less infection, will not have to take care of too many people. Next, please. So our former president Ho Chi Minh has a very famous saying, and we keep hearing that all the time in Vietnam, that he said that the easiest task wouldn't be complete without the people. And the most difficult task would be performed by the people. So the people is very important in our history, and I think in the human history. So the people here, represent the community, in particularly when it is organized. Next, please. We see that community and civil society can play critical role in health, in UHC and health security, especially to leave no one behind. And it's just a statement I would like to make is that investment in community and civil society is indeed investment in common good for health. And I hope that everybody agree that we really need to invest in common good for health if we want to achieve UHC and if you want to have health security. But investing in community and civil society is a way to invest in common good for health. Next, please. I just want to go to the end of my presentation to say the importance of global response, the global common good, because right now in Vietnam we have more than 2 months without any community transmission. We can travel freely in the country, but in fact we are confined in our own country. We cannot get out. We cannot go out of the country, and worse than that, we many job life of people have been severely affected. In July, our government already estimated that 55% of workers would have their income lost or reduced. We have a fantastic COVID response, but as long as every other country are safe, we are not safe. So and no single country will be safe until everyone is safe. So I think COVID is such a striking example of how health is a common good, and we need to really invest in the global common good. The local identity is important, the national identity is important, but we are together in this globe. So the global identity is also very important. And I will end my presentation with a picture. You can, yeah. So the baby, a baby that was abandoned by the parents living with a grandmother, and so the community during the COVID identified the family and brought them food. You can see en masse, and it is how we are together in this. It is a common good that the community was doing during the time of COVID, so that no one is left behind. Thank you very much, and we'll wait for the discussion. Thanks.
Thank you very, very much indeed, Juan. A very powerful reminder, a very, very powerful case of the need to invest on a community and civil society. And in particular, with the COVID, we learned that again and again, that is not only a complement, but as fundamental as the health system response to beat the COVID pandemic. So you said, I think I'd like to remind us of that, it's not only the right thing to do, but the critical thing to do. So I would like to add in there, one, with your permission, that leaving no one behind is the right thing to do, is the ethical thing to do, but also it's terribly expensive to leave someone behind for the well-being, for the sustainability of the society, for the financial sustainability as well of our societies. A very powerful case there that will come back in a minute during the debate. And now, last but not least, in this row of very, very good presentations, and encouraging colleagues to please add to the chat box, add questions, add contributions. We'll move in a minute how we bring all that together to make a case for common goods. I'd like to introduce our good friend and colleague, Sonman Kwon, Professor, School of Public Health at the Seoul National University in Korea, and former or current president actually of the Korean Health Economic Association. Sonman, your job now is to show us how these common goods for health have played a have played a key role on UHC, have played a key role in universal health coverage, a key role dealing with the challenges of the pandemic in positive as well as in negative ways as well. Sonman, the platform is yours.
Thank you. Thank you, Joseph. Let me share my screen. Hope you can see the slides, right? Well, thanks a lot for inviting me to join this very important and exciting session. So let me briefly examine the Korean experience in the response to, in the preparedness and response to COVID-19 with you. Well, this is the daily confirmed COVID-19 cases and deaths in South Korea. So at the peak, we had more than 800 cases in early March. So after that peak, so the number of daily confirmed cases have been stabilized, although we had a kind of second wave in mid-August. And at that time, we had about 150 new cases. But after that, again, another is also stabilized. And nowadays, the kind of average daily confirmed cases about in the range of 100, 120 recently. So what are the key elements in the preparedness and response to COVID-19 in Korea? There is first of all, a huge investment in the common goods for health, especially in terms of preparedness. And in a sense, Korea was quite lucky, I think, that because we had a painful experience of MERS, Middle East Respiratory Syndrome, about 5 years ago. And at that time, we had quite a large cases and mortalities, probably the largest outbreak outside of the Middle East region. So it is a good experience in a sense to Korea. So there are a lot of discussions and reflections after the MERS experience. And then consequently, there is a series of revisions of law and series of investment. Most significantly, we strengthened the Korea Centers for Disease Control, increased the budget, increased the personnel, especially increased the number of epidemiological investigators. And also, recently, this Korea Center for Disease Control and Prevention even expanded to a bigger agency. So now it's a Korean agency for authority for disease control. So the strengthening of KCDC was a major momentum after the MERS about 5 years ago. And another investment was that we introduced a series of policy changes. For example, that the new law allowed aggressive contact tracing, mainly based on interviews. But in case we need further information, the law, had make it possible for the Ministry of Health and Welfare to use the credit cards, data, to use the mobile phone location, and also CCTV data. So the law made it possible for the central ministry to collect this information for the purpose of contact tracing within the boundary of law. And also at that time, we realized the importance of the collaboration and coordination between central and local governments. So at that time, there's some coordination failures between different levels of government at the time of MERS. So after that, we realized that the coordination is quite important. And also we realized the importance of testing capacity and early testing after the experience of the MERS. So as a result of this, I would say high level of preparedness, Korea had a minimum restrictions. We didn't have any lockdowns during this COVID-19 era. And the impact on economy is not too bad. And for example, this figure shows that Korea had almost all countries around the world have experienced that the negative GDP growth, but Korea, compared to other countries in OECD or in Europe, Korea had been experiencing a relatively smaller negative GDP growth since this COVID-19 era, partly because that the government invested in this preparedness and successfully contained the rapid spread of the infections. But also, for response to a COVID-19, universal health coverage played a key role because it reduced or eliminated the financial barrier to access to testing and treatment. And also, UHC means that we can effectively organize the healthcare delivery through the purchasing mechanism. So for example, the cost of treatment, the major parts of the treatment cost is covered by national health insurance, but copayment is free for the COVID-19 patients because this copayment part under NHI is paid by the government budget in case of communicable disease such as COVID-19. And also cost of testing ex ante free for some conditions and also ex post free if a person is tested positive. And in reality, the majority of the testing cost is free because there are a lot of initiatives by the local government. They provide additional funding for the free testing for COVID-19. And also the national health insurance rapidly responded to COVID-19, such as it quickly expanded the benefit packages for medicines and services related with COVID-19. And also this National Health Insurance Service Agency provided exemptions and discounts for the national health insurance contribution for those people who are affected severely and for the vulnerable population. And especially at the early stage of this COVID-19, many hospitals suffer from a sudden reduction in cash flows because many people are reluctant to use healthcare. So now this National Health Insurance Service introduces this advance payments to hospitals. So they pay first, like say 80 or 90% comparable to the previous year's reimbursement level, and then they provide review and assessment later. And this National Health Insurance Universal Coverage Scheme is quite important also from the perspective of data infrastructure, because this NHI covers the entire population, 100%, and also people have unique ID. And it's very important, the Korean NHI covers the 100% of healthcare providers, both public and private providers. Actually, it's a legal mandate. So it's a kind of contracting, but it's a mandatory contracting. No providers can opt out. So although more than 90% of the hospitals are private in Korea, but 100% of those private providers should join the national health insurance. And this national health insurance system has a very good data infrastructure. So all private providers, they participated in the testing or treatment. So it contributed to the effectively coping with the surge of patients. And also like this NHI provided rapid response in service delivery, such as the separate pathways for respiratory patient from non-respiratory patient from diagnosis to treatment. So we rarely had a hospital exclusively for COVID-19 patients, but rather in a hospital, that hospitals have two different pathways, one for respiratory patients, the other for non-respiratory patients, and also there are separate words for those COVID-19 or respiratory patients. And also telemedicine was allowed, although in Korea, very unfortunately, telemedicine is not allowed in Korea because of the opposition from the Korean medical associations. But during this COVID-19, this telemedicine was officially reimbursed by this national health insurance system. So this is a drug utilization system. So, I mean, all outpatient prescription information is transferred, I mean, or exchanged between medical institutions, pharmacies, and National Health Insurance database. So this drug utilization review was effectively used as a monitoring mechanism to examine potential patients, because when a person has some kind of fever or some similar symptoms with COVID-19, I mean, it is possible that they can visit pharmacy and they can purchase some medicines without doctor's prescriptions. I mean, they can purchase OTC medicines, but even that type of all kind of prescriptions and medicines used was, I mean, that data is transferred to this National Health Insurance Service. But there are a lot of, I mean, still many challenges. But first, let me briefly see what worked. I mean, in the case of Korea, the investment in preparedness for health security and pandemic, it worked. It paid off in a sense in terms of the little negative impact on the economy, and also UHC was quite pivotal in the effective response, because it means no financial barrier to testing and treatment. And also national health insurance covering the entire population and all healthcare providers, both public and private providers. It provided very effective database. So one of those presenters presented the role of data infrastructure. But in the case of Korea, this National Health Insurance Service itself provides a very effective and excellent data infrastructure for UHC and also health security. And this information system is also used effectively to ration face masks at the early stage, because at the early stage, we run short of the supply of face masks. But at that time, the government introduced a rationing, like one mask for every 2 days. And then this type of NHI data was effectively used by pharmacy to allocate face masks. And also working with the private sector in testing and treatment was good. But there are many challenges we had. For example, like a vulnerable population, we had major large-scale infections in the long-term care hospitals, long-term care facilities. And during the COVID-19, many people order food, I mean, everything. So the delivery services was so, I mean, there are a lot of workloads, like industrial hazard issues for those daily workers, so vulnerable population. And also when the school is closed, we are worrying a lot about the increasing gaps in the academic performance when the school is closed and when we have internet-based classes. And although in principle, private providers participate in the treatment of COVID-19 patients, but still, it is mainly the public hospitals that played a key role in the treatment of COVID-19 patients. As I said, although less than 10% of Korean hospitals are public, but those small number of public hospitals, they accounted for more than 80%, almost 90% of the treatment of the all COVID-19 patients, because private hospitals, they do not have a strong incentive to proactively invest in pandemic preparedness and treat COVID-19 patients. So still, I mean, we know public-private partnership is so important, but still, it is the public hospitals that should play a key role. So public hospitals' role is still important. So this is a big, lesson for Korea. And also, well, with a very weak primary care healthcare system, Korean system is very much of a hospital-centric healthcare system. So I'm sure that if Korea had a stronger public primary healthcare system, we could have improved effectiveness of our response. Thank you. Thank you, Joseph. I cannot hear you, Joseph.
Apologies, the organizer didn't unmute me. I'm under the control of the organizer. Thank you for unmuting me finally. Sunman, that was beautiful. This is everything I wanted to know about South Korea and the success and the failures, but mostly the success with the COVID pandemic. You highlighted beautifully the rationale for UHC, the rationale for common goods for UHC, showing one of the main issues we face in this continent, this European continent, the need to decrease the financial barriers for access to services, for testing. It's been one of the barriers in this continent. You showed some of the failures, the need to invest in public hospitals and in primary healthcare. And another element which Agnes was reminding us, which is fundamental, it's a fundamental common good for health, which is policy and coordination and regulation. You showed how the coordination, central, regional level, how investing in public health services like regulation made a difference for testing, for coordinating policies. This chimes beautifully with our recent EuroHealth, the Journal of the Observatory, where we've been looking at governance, successes and failures in this continent around COVID. So that's beautiful. So colleagues, with a bit of delay, I apologize. We are now moving to our debate. There have been lots of fascinating questions already in the chat. Thank you very much. I like, however, to move our debate rather than on the particular questions on the presentations, which are really, really good. I like to move us into not only the why that Agnes has put forward very nicely, the why we did not invest before in common goods as much as we should, but how do we now transform? How do we now, as she was saying, increase the salience of the common goods in these issues? How we have this collective identity at the subnational, national, and global levels? How do we justify investment in these common goods, common health goods? What kinds of transformations and examples we can put together? And the second question, because much of what we do here today is what platforms within countries and across countries, many of you are in these platforms. Obviously, UHC 2030 is par excellence a platform. What we can do from these platforms to champion, to harness this effort. And to start this debate, we asked our colleague from Tolbert Niensha, Senior Research Associate in the Johns Hopkins, Bloomberg School of Public Health, to tell us how Ebola was a good example, an excellent example of how to make a case for common goods for health. How Ebola, like we saw in South Korea, was a good way to justify the common goods for health. How having those common goods for health in place, as UHC, made a difference in addressing Ebola, and how these lessons can be good can be very helpful for the common goods for health for COVID. Tolbert, the platform is used to introduce this debate and to put some of the elements for this debate using Ebola as a case study.
So Joseph, thank you very much, and thanks to our presenter for for the brilliant work. I know our participants will agree with me that they have been excellent presentation. As Joseph said, my name is Tobin Miswat, Senior Research Associate at the Johns Hopkins Bloomberg School of Public Health, and led the Ebola response in Liberia as the incident manager. For those of you who know what Ebola did to West Africa, I was the leading that managed the multinational, multidisciplinary team that responded to the Ebola outbreak. And prior to that, I was in the Ministry of Health as Deputy Minister of Health and established the National Public Health Institute there. What I attempt to do now in this session as a discussion is to put it into context and how, like Agnes from WHO mentioned very well, that when governments and countries are not prepared, the kind of difficulties that they are faced with before Ebola, during Ebola, and after Ebola, some of the systems that we managed to put in place. But we listened to very brilliant presentations from Agnes on the common goods for health. When I accepted to be one of the contributors to the special series on common goods for health, I took my experience into account on what are those things that work well, what didn't work well, why Ebola affected the West African countries and what happened. And basically, the three most fragile countries most affected with Ebola, Guinea, Liberia, and Sierra Leone are fragile country. And before WHO declared the outbreak in West Africa over, we had about 28,000 cases and 11,000 deaths. But then quickly, the countries were able to turn around, and then we saw system building, establishing National Public Health Institute, as my colleague Sunman said, from Korea, putting in place like a replica of the US Center for Disease Control, taking lessons from what the shock that we feel, that we saw that a tale of two outbreaks. What happened during Ebola, and then after Ebola, we saw flare-ups of 3 Ebola cases, same scenario where the Ebola came from across the border. We saw that and we were able to deal with the flare-ups of the 3 cases very efficiently with limited casualty of mortality and mobility. And then we dealt with cases of meningitis, we dealt with Lassa fever, we dealt with measles. The fact that we invested in health security systems, building response system, emergency operation, working with the communities, investing in common goods for health have paid off. And I don't want to use this time to define it because Agnes defined it very, very well on investing in common goods for health, how it paid off. What I'm attempting to do now is to give you granularly and then at a high policy level on when government take actions, collective actions, how that can work well, and then working with the community. We've seen that the global South, like South Korea example, Liberia example, and in Africa, establishing the Africa Center for Disease Control, establishing national public health institutes, and investing in preparedness and response. These are common goods of health that have paid off. Today, these countries are doing very, very well in responding to the COVID-19 outbreak as compared to other countries. And then actors coming together. I've seen government agencies, civil society organizations, put in supply chains, logistics systems, working with the communities, looking at one of the common goods for health that worked in Liberia was the establishing of the One Health Initiative. The animal health sector, the human health sector, and the community sector coming together played a very, very crucial role in doing that. And basically also, why invest in common goods for health? This is the thing that was presented very well. There's a tiny fraction of investing in the economy, preparedness and response. The cost is so tiny as compared to not taking action. So by government taking action, we can save more lives. Some of the experiences we learned from Ebola if we are capitalized on them and invested in institutions across the world, early warning systems, we would have made significant progress, and COVID would not have devastated the entire global community today of what we see. So those are some of the issues that we were able to do, and then investing in individuals and all of that. So prioritization is also critical. Like I heard from across our colleagues for community level investment, common goods for health, data management and all of that. But convergence of common goods for health financing, investing in education, immunization services, nutrition, water, sanitation, and hygiene, and bringing these things together are the investments that are needed in common goods for health that are very, very much critical to the global community. So basically, some of the work that we try to do as part of the expert team at Johns Hopkins is to support some of the jurisdiction and states in the United States, and also move to low middle income countries that need the support left. For example, last week I was speaking to Latin American countries and sharing some of the experiences that we have with Ebola and how we were able to manage that. So fellow participants, this opens up our discussion on how important it is when I contributed to the series, collective actions by government and prioritization of investment, like we saw in global health security. The last thing I want to share before I give the floor back to Joseph, because I want to make sure that we manage the time, is that we've seen countries like the global south that have managed infectious diseases like MERS, that was Korea, like SARS, like Ebola in East Africa, in West Africa, have done very, very well in managing COVID and dealing with those infections as compared to the global north that are not used to some of these infectious diseases and are dealing with non-communicable diseases. So I'm a champion of investing in common goods for health because it saves lives. Thank you, Joseph.
Thank you very much, Tolbert. You're not only a champion by belief, but you're a champion by evidence. I think that couldn't be stronger. I won't have the temptation to summarize it because you made it very, very clearly, very clear case in the case of Ebola. Colleagues, some good news. Some God out there in the organizing the conference have given us an additional 10 minutes. I hope the participants can stick with us these additional 10 minutes to be able to have a good debate. So we have beautifully another 25 minutes of debate, then followed by 10 minutes with the conclusions from Agnes. So summarizing again, we have the why. We heard from Agnes why we have and what been the political constraints. And I don't want us to talk about the political constraints, but how do we address these financial and political economy and organizational constraints to invest on common goods, how we transform our systems, and in particularly how we increase the salience of common goods for health, how we foster this collective identity at the subnational, national, and global levels. So panelists, this is the question to you. Attendees, this is the question to you. Panelists, you all have the chat. I'll ask you to look at the chat, and any questions have to do with your presentations, you keep them in the back of your mind, and at the end, I'll ask you to summarize, and I'll ask you to address these questions very briefly. But now, please, I'd like us to focus on the forest of the common health goods, not on the individual ones, but what are the lessons for individual areas for the forest, as it were. Okay, who wants to start, please? You don't want me to talk anymore. I talked enough already. Any lessons? Sonman, let me start with you. If you don't start, I'll ask you, which is worse. Sonman, you did very well in South Korea. No doubt about that. But still there are a number of public health goods like common goods for health, like primary health care. And we'll go back to Beth in a minute following you. Why? Why? After all these years preaching for primary health care, there's still not enough investment. Do you think now, seeing some of the failures in COVID, we have a chance, or we still continue being the Cinderella? Because actually in public health, you seem to be doing very, very well. It's impressive about your ability to test. The whole continent should learn an awful lot from you, because we've been very lousy in many of our countries over here. Over to you, Sonman.
Sorry, but I don't have a good answer. there are a lot of like a path dependency. For example, there's not enough investment in primary care, not enough investment in the public sector. Those two aspects, we have been like this for a long time. And unfortunately, as I've been working on Korean system for a long time, to some extent, the so-called insurance-based approach a bit contributed to the decreasing role of primary care and decreasing role of the public hospitals. Because after this insurance is introduced, people keep on, people say, okay, now I have the capacity to pay for expensive hospital care. So they keep moving to the hospitals. And also when the demand for healthcare increased after this funding mechanism, the increased demand for healthcare was met by the increasing supply from the private sector. Because I think there's some misunderstanding that okay, the public role is just increase the role of the funding rather than strengthen the service delivery. So I think that kind of misunderstanding thinking, and then like for the last 30, 40 years, it worked like this. So I think that some path dependency is very important factor in Korea. But at the same time, in the investment in the preparedness itself, it worked because especially after this COVID-19, people realized after like a MERS 5 years ago and COVID-19 now, people fully understand how important it is, how scary this experience is. So I think people are ready to invest in preparedness, but how to prepare, how to invest, still the details on the policy options are affected by the path dependency. Perfect. I think.
Path dependency, and context. We always finish like that, but we have to go beyond that.
Sorry.
In different, no, I agree with you. In different contexts, we need to be able to communicate, to steer in different ways, depending on that path dependency and its context. But here we are about the question I've been asked to ask you is this fostering of collective identity, is how to increase the salience. Clearly, the evidence is there. You guys have been impeccably good at presenting the evidence, but that may not be enough. I mean, maybe we want to hear the political economy. Beth, you want to tell us a bit more about primary healthcare? And maybe Agnes, afterwards, what about the private sector? I keep hearing in the UHC debate that if we don't bring the private sector on board, particularly low-income countries, we don't have a chance. So how do we get the private sector as well in these common health goods? How do we get them on board? But first, Beth, primary healthcare. Where is the salience? How we strengthen that? Because listen, how many years since Almaty? And now 2 years since Astana.
Yeah, 42 since Alma-Ata. So,
yes,
but who's counting? I think it comes down to a matter of incentives. There hasn't been enough incentive to invest in these common goods, particularly in the PHC space. And I think, I guess I'll give an example of sort of looking back at my presentation where I was talking about some of those, quote, intangibles about PHC that are so important in building a strong system and actually do require investment and attention, but are very difficult to get a lot of interest around. I liken it to sort of a situation of, whether a leader wants to invest in a road or a road maintenance fund, right? You want to invest in a road because you can have a ribbon cutting at a road, because people can drive on the road, because you can name a road, and every day it becomes very clear what you've put in the road. It's the same with the health facility. You want to invest in a building because the building is sort of a tangible manifestation of the investment and the commitment. But it's, you know, if you don't invest in maintaining that road, if you don't invest in the kinds of interactions that go on inside the building, if you don't train people properly, it doesn't matter how many people you've hired if they don't know how to do their jobs properly, if they don't have the tools to do their jobs properly. And so I think that what we need to sort of reset our expectations about what quality looks like. We need to measure it better. We need to do a better job of holding people accountable for it. And we need to create an incentive structure both at the country level, and I mean this across countries, LMIC, high income countries, every country. Yeah. We need to create an incentive structure at the country level that rewards thinking in an integrated fashion. We don't have that right now. And we need that same type of incentive structure at the global level with global institutions. We also don't have that now.
Well, exactly. Isn't that a mea culpa we should be singing now? That's my second question today for all of you. How do we get these platforms to harness this common identity, this rationale for incentives? I mean, we can't criticize, we're not criticizing, of course, we're talking about member states, but how are we as platforms, each one of us are in one of several of these platforms in actually creating this incentive structure? How much is the bilaterals are strengthening incentive structure? They still want to cut ribbons, many of them. Why are we failing to make the case? What do we need to do? We're talking about managing the donors. We're talking about donors coordination. Let's be a bit self-critical today. Few people listening to us. Let's be a bit self-critical. So, Agnes, let's be self-critical because we're doing a great job from WHO, bringing donors together, bringing strategies together, running the UHC. How can we do further on these platforms and on the private sector?
I think the message comes out so loud and clear from this pandemic, and the example of Korea is extremely powerful, because first it really says you need to invest upstream, you need to invest ex ante, and these investments in preparedness that stem out of the lessons learned from the MERS crisis have been absolutely essential. In this case. And the world should have learned in the same way from the Ebola crisis. Tobias said this earlier, that it's something that needs to happen everywhere, not only in Korea, not only where previously epidemics have threaten overall global health security, but that the security of everybody hinges on the security of every country. So that global health security is conditional on the health security of countries themselves. So global common goods depend on national common goods in a large way. And then there are some areas that are global, such as international health regulations and R&D and the sustained financing of global surveillance systems, as well as investments in a common coordination system, which WHO is doing its best on right now as the kind of Ministry of Health of the world. So this needs to be strengthened. But I think the other message is exactly also coming out of Korea is, yes, those fundamental common goods are important, but beyond that, we need a health system that is universal. And that has built a social contract in which there is trust and there is access. And that has proved absolutely critical. And we know that it's not the case still in many countries. But even then, and I also take the sort of lessons learned about what has not worked, is we see that the dichotomy between public and private sector has been a difficulty. And it's certainly probably one of the reasons European countries have been struggling with this pandemic. And we've seen at different stages, the public sector being overwhelmed and then the private sector actually almost closing its doors because not receiving the non-COVID patients, but not really being involved in the response to COVID. So that full inclusion of the private sector is as the private sector provision through incentives and integration, coordination, and payments by the public purse, we see is an essential step, because it goes at the heart of having systems that are ready for tomorrow. Clearly, for example, and you know that better than me, Joseph, because you were involved in the review of European systems, the European response, is the European response did not integrate the buffer that allowed surges, right? They did not, and they also facing that problem of coordination with the private sector. So I think that clearly there are some incredible benefits that could be reaped if we would invest in systems that are much more people-centered on a primary healthcare model. But it's really beyond primary healthcare, because it's also rethinking the way hospitals are incentivized, are funded, and how they articulate with the primary healthcare services.
Thank you. Let me ask now very briefly, and then I'll bring Julia on board with some of the questions of participants. Let me tell you what I'd like to do now. Time is running very quickly. So I'd like to ask Craig on the incentives. On the incentives, in your case, Craig, on the incentives we need for information systems that are not there. Why are they not there when it's really the common good par excellence? And on the same to civil society and community participation. Then I'll ask Julia to put some questions, and I'll ask then short reflection from all of you on the platforms, on the international platforms, on what do you want from these platforms? How do you want these platforms to support you at national level, international level? Okay, so first Craig, then on the incentives. Craig, incentives in information systems, please.
Thank you. And I got two main responses. I think in terms of the incentives, need to build upon getting away from each individual entity, donor, program, hoovering up data and shifting much more to, well, how can data be used for action in a more integrated way? And the crux to that is, how do you get integrated ways working? And from our perspective, it's very much what Juan was saying, using communities, getting civil society engaged and having a much more bottom-up approach for accountability, where communities are linked to the incentives of planning, implementing and budgeting services, where the incentives are much more about data for action at the sharp end. The second thing I'd like to say is really using the platforms is not necessarily inventing or making or creating new platforms. It's building at national level the platforms that already are owned by governments, that are working, build on that national capacity, don't duplicate. Sometimes there is a pool in different ways to kind of fragment and create something new because it's shiny, but build upon the things that are owned and working. And I think that would help the incentives for all partners considering. Thank you.
That's absolutely perfect. It already brings us to the next, the final way I wanted us to conclude on the platforms. One.
I think at the beginning, when Annette presented, she already mentioned that the reason why we need common good for health because of the market failure, and because of health is.
One, I think we're losing you.
Yeah, if we want to. Sorry, do you
yes,
hear
we hear you. Go ahead.
Okay. So I think in order for the government to invest in common good for health, okay. So let's say is that common good is need to be collectively financed, and we should not forget the human part of us. So we all talk about data and things and information. That's very important. But in everyone's chest, there's a heart, and that is humanity. I think we should mobilize the humanity part of the human being more than just the number. number is important. I don't disregard it, but I think we need to do that humanity part. And the collective action can come from that. And we can do that with civil society and community. But if we mobilize civil society and community good enough, strong enough, we can bring about political incentive as well, because the government needs votes, the government needs people support. And if we can build the common sense among the population, when it comes to UHC or health system and community system, it will eventually build the political incentive. We haven't invested enough in community and civil society. We all say that, oh, it's needed, etc., but we don't. And just to respond to the question about the informal worker, again, we need civil society and community advocacy to raise awareness about informal worker, but we also need community and civil society to mobilize the informal worker to be a part of UHC movement and UHC operation in the country. So I cannot stress enough the importance of civil society and community, but we need to invest in it to begin with. So
indeed, lots of platitudes and lip service about civil society and community, and not enough investment, because perhaps the only way to address this political economy is starting with the grassroots. And thank you for the mentioning of the heart and humanity. Colleagues, Julia, I'm sorry I didn't bring you in. Let me bring you in now. And now in a couple of minutes, summarize a bit what our participants are saying, what are their views, what are their contributions, and then I'll ask those in the roundtable to summarize in a minute or so, each one of them, what they heard, what they want us to take home. Julia.
Thank you very much, Joseph. Thanks a lot to the participants also for being very active in the chat box. In the meantime, we have many reflections and questions that I've been trying to answer already. However, there were a few questions which I also, I mean, we cannot answer to all the questions, even though we've tried to tackle them. But there were a few questions that perhaps I would like to highlight and ask the panelists to provide their reflection. There was one question specifically for Beth. Have there been challenges on the way to consider findings drawn based primary care performance assessment by National Health Assessment? And has PHCPI initiative a role to monitor whether countries tailor their intervention actions to the challenges identified by the PHC performance measurement? So this is one question that has been asked to Beth. Another question again on PHC. Have you elaborate on what type of benefit packages were developed for COVID-19 patients at the PHC level? Also, there are two other questions. One from Christy Braham. I'm wondering if you have any recommendations for achieving UHC in the context of COVID-19 through considering all of those working with the informal economy. So this is targeting the informal economy, how to best include them, given that many informal workers remain excluded from health insurance schemes, but actually make up the majority of workers in many low middle income countries. And then I would like to highlight one other question, and perhaps Agnes could be also maybe responding to this one, is a question by Jennifer Dabbis. What about the next phase? After the development of the vaccine, what is the new normal? How do governments address the challenges on NCDs, for example, and on the scaling down the other services? So these are a few questions that I have summarized from the chat box, and perhaps the panelists could try and answer them before we then conclude. Thank you very much.
Excellent. Thank you very much indeed. So I have for you, Beth, you have another hour or so to respond about performance in primary healthcare and benefit package. Owen, you'll take the question, please, about harnessing this informal economy, bringing them on board is a reality. Agnes, another hour for you on live after COVID. Hopefully there's live after COVID. So I'm going to do the following. So I'll get Beth, Juan, and Agnes to reflect on these questions first, very briefly, and then I'll ask Craig, Tolbert in particular, I want to bring back, and Sonman about your dream role for international platforms to support you in the countries to work together to bring the salience of common health goods. And then Agnes, at the very end, you summarize everything in 5 minutes. There you are, very easy. Beth, couple of minutes for what you should do in an hour, really.
Sure. I'll be very brief, and thanks for the great conversation and the great questions as well to the attendees. So, first in terms of the challenges, considering findings drawn based on the primary healthcare performance assessment. So, PHCPI works with countries through our partners to conduct vital signs profile assessments, which are sort of snapshots of a country's primary healthcare system. And then countries use those in various different ways to drive decision-making and strategic development. So we often see pieces of the vital signs profile get folded into a GFF investment case or a program document for a World Bank program or a strategic plan for PHC, as is in the case of Ghana. And then countries themselves can determine how they want to invest funds, ask donors to invest funds, change policies and prioritize policy change based on what they find in their vital signs profiles. In terms of PHCPI's role in monitoring whether countries do that, that's not PHCPI's role. The vital signs profiles belong to countries. They represent data that countries have and that countries put together, and a lot of work on the part of country ministries in partnership with PHCPI, but they don't belong to PHCPI. And really what we hope is that the vital signs profiles and any products that come from the vital signs profiles, for instance, a lot of countries are very interested in subnational level profiles, as you might imagine, because that helps them get at least one level closer to where the real investment and decision-making needs to happen. What we hope is almost that the entire community of stakeholders can build a community around vital signs profiles where they can use that as a way to hold the government accountable. The government can use it as a way to hold themselves accountable, and non-governmental actors can use it as a way to engage in conversation about prioritization and resource allocation with the government, and then hold them accountable. So that's not something that we do. We like to think that we enable it by helping countries to put out these public assessments of their primary healthcare systems. In terms of benefit packages, I think I'll sort of flip the question a little bit. The universe of interventions that are necessary to detect and treat COVID are in many ways things that should be part of that should be part of a health system. Many of those should be part of a primary health system, and many of those are not part of the primary health system, but are part of the health system overall. And Agnes just was talking about how there's a primary healthcare system component to it, but it is broader than that. So what we like to look at is how countries actually leverage their primary healthcare systems to address COVID, as opposed to providing sort of specialized services for COVID. And, what we see is, I think, let's say in the case, very briefly, in the case of Colombia, because of the way their health system is put together, they have really excellent empanelment. So they know who each center knows who its patients are. And they know what their needs are, which means that they can actually turn on a dime, and it's much easier to understand who's at more risk for COVID. Did those people need to be staying home and receiving home-based care as opposed to coming into a clinic? So you use elements of strong PHC in order to respond, as opposed to it being a set of discrete interventions in and of itself. But that's just one example that I'll give.
Thanks. Yeah, risk assessment is fundamental primary healthcare. We're running a bit late, my fault actually. One very briefly on the harnessing of the informal economy. Very briefly, please. Informal economy workers.
You're asking me, informal economy workers?
No, I was asking one, please.
Oh, okay, good.
That was the question for her, yeah. You are muted, Juan. You are muted. You are muted. Apparently they need to unmute you.
Doesn't control her microphone.
Yes, I think this is the host needs to control unmute one, please. Meanwhile, while we wait for one to be unmuted, I'll ask Tolbert very briefly on the international platforms of how you expect those to harness to support this common identity, the salience of common goods for health. Very briefly, Tolbert, please.
Thank you, Joe, and thank you to colleagues. I think the policy option and policy mechanism on the platform and intervention to catalyze action for UHC and common goods for health is basically looking at the sector-wide approach. The sector-wide approach is led by government and expanding investment, government expanding investment, and actually what the platforms and donors, community, private sector can do is, minimizing the fragmentation and working as a one team to support one investment plan that takes in context all of the 6 building blocks, leadership and governance being a pillar of that, and then investing into the pillars that we saw with common goods and health that were mentioned by Agnes. This, for me, we concretely look at health security, investment in international health regulation, countries looking at the global health security agenda, and then basically it will protect all of us. Our security for health will be protected. Then we can talk about moving in the direction of UHC 2030. Thanks, colleagues.
That's perfect. Excellent priorities. On Craig Sonman, oh, you big one. I have to bypass you now. I apologize, lousy chairing from me, because I need to pass it to Agnes to give us the final conclusions, in which she's actually going to bring some of the questions I was bringing to you. Agnes, to your last 5 minutes for concluding us. Thank you.
Thank you very much. Thanks to all the panelists, and thanks for the participants who have been very patient with us and staying in this conversation. So if I try to summarize today's point, it brings a wealth of lessons highlighting the importance of collective action to strengthen health systems, to manage future shock, building on COVID-19 experience. And on the question of what is next after the COVID-19 vaccine, well, what is next is building a different system, is reset, pushing the reset button so that we build the health systems of tomorrow, not the health systems of yesterday. We are no longer in the 20th century. And there are specific opportunities that are identified to promote collective action on public health priorities around the categories of common goods for health. And a lot of examples have been given today from Vietnam, Korea, the civil society, and Liberia, etc. So we are talking here about moving away from a one disease at a time approach, when we would look at responding to one disease from end to end, from the technology to the actual delivery to the individual, to a much more function-based health system that is people-centered, population-centered, and takes into account the environment, the ecosystem in which humans live, and takes into account the structure of the population, the forces, the political forces, the societal forces that play in order to build a social contract that is grounded into a common identity. So we need policy and coordination with a strong health financing system. It's key to respond to an epidemic crisis. If one thing we've learned from this crisis is labor taxes on people who work are not very well suited to health crisis. They're not generally suited to finance healthcare, because whenever you lose your job, then you lose your coverage with healthcare. So we need to have something that protects your access, that is not dependent on your job. That's a major lesson. We've already had a lot of evidence on that, but this sort of the COVID-19 pandemic put the last nail in that coffin. We need data as a strategic asset for health security and for UHC. We need freedom of information, data protection, and sharing policies and agreement. And we need an alignment among partners to strengthen the data governance so that we actually have a mechanism that allow the people to have access to those data that are provided in a transparent way and are questionable and used in the public debate. We need also to learn from lessons and good practices across countries on how to identify and protect vulnerable groups. Taxes and subsidies, we know that that NCDs have really, the high level of NCDs have been a major contributor to the propagation of the epidemic, but also to the high mortality linked to this epidemic. So we need really specific measure to invest more in health promotion and in implementing health taxes on tobacco, on alcohol, on sweetened beverages, on sugar, on trans fat, etc. We need to use new fiscal policies that respond to health, as well as making sure that there are no financial barriers to critical services. And that is again ensured by financing system that bring everybody together. Regulation and legislation. We know we've been going through over the past decades movements and forces that have pushed for deregulation. And what we've learned from this pandemic is how much regulation is important, because regulation legislation do address market failures. And we need regulation that through investments in the appropriate legislations and laws and investments focus on preparedness. Investments in common goods for health need to be built in national budgets. We need public collaboration with the private sector, particularly on testing and treatment. We should really more and more make sure, as is realized in Korea and in many European countries, that we need to have one delivery system, and the statute of private and public should not be an obstacle to the entire spectrum of health providers to respond in case of a crisis. And we need environment for multi-stakeholders engagement. You were asking about which platforms for the future. We need societal dialogue platforms. And you see that in all countries, there is a lively public debate, and you cannot respond to a pandemic of this magnitude if you don't have trust of the population that is based on transparency and dialogue, in the sense that people are listened to as to what they expect from their governments, what they expect from the public purse to fund. So buildings, institutions of dialogue, we've heard from the experience of Vietnam, the institutions, not that consult civil society occasionally at when there is an opportunity of a donor-funded program. No, it needs to be a conversation, a national conversation with a national civil society and a government that engages its citizens. We need to move out of any thinking that this can come from the outside. This has to be national conversation that create national identities. And the importance of population services also, that we need specific investments in public health programs. And in that first line of defense, that is primary healthcare delivery systems, enhancing the health system's resilience to prevent, detect, and response. We see that systems have a hard time to track, trace, and test. We really need systems that are much more anchored in communities to be able to do that. And we see that many systems are failing to do that. And the measures to reach out to vulnerable groups, to older people who have been in many ways some of the most affected, have been the most affected group, have been the first victims, elderly, vulnerable people, elderly living in
Agnes, they are threatening us to cut us off.
Yes.
Sorry about that.
So,
because I need to start the next
one
session. Not your fault, my fault.
Yeah.
If you want to
really,
wrap us up, please.
So to conclude, we have good ingredients to respond to this call of action on financing the common good. This should be the priority. This is the step 0. We need to promote a coherent health system response, build on engagement of citizens with strong civil society voice. And really the platform of UHC 2030 provides a strong global platform for that collaboration, to move beyond focusing on specific disease to system building, building a collective identity, a common identity that help increase the salience of the importance of investing in health across communities, enable community engagement and grassroots initiatives to demand action from political leaders. Thank you very much.
That's absolutely perfect wrap up. Thank you very much indeed, and have a nice day. Thank you.